compliant patient and a willing and inquisitive examiner. Thank you very much. The next speaker is Dr. Mansi Jory. She will be speaking on importance of history taking and examination.
Good evening, everyone. I would like to thank AIOC and Dr. Swati ma'am for giving me opportunity for the presentation on this platform. So my topic is, are we still missing something? Role of systemic workup in glaucoma. So as we all know, glaucoma is a multifactorial optic neuropathy that causes a characteristic acquired loss of retinal ganglion cell and atrophy of optic nerve. Number of people suffering from glaucoma in 2013 was estimated to be 64.3 million worldwide and expected to increase up to 76 million in 2020 and 111.8 million by 2040. So here we see how intraocular pressure is the only modifiable risk factor. So we can see here that in spite of a normal IOP, we have a normal tension glaucoma as an entity, and in presence of high IOP, we have ocular hypertension and open angle glaucoma. So the question is, IOP is the only risk factor? We have all seen patients well on their target continuing to progress. Why does it happen? Is our target wrong? Are the patient not compliant enough? Are there other factors, and how do we identify them? So can glaucoma progress when IOP is well controlled? Answer is yes. What else do we evaluate and treat in glaucoma patient? Let us see. So how do we identify those? So obviously any patient who is progressing needs further attention. Look into the compliance in detail. Look for the IOP fluctuations. Look at the cause for the fluctuation. Is it a fluid overload? Could it be a tight collar? Or could it be a periodic breath holding like in some yoga asanas or in some musicians? So the importance of history comes into play. So what else we have to ask in a glaucoma patient? We have to ask for a systemic hypertension. Is it controlled or is it over controlled? We have seen this that in patients who are having their antihypertensive medications at night, they specifically can have a dip in their diastolic blood pressure. Secondly, we have to look for any compromised ocular perfusion like Raynaud's or sleep apnea, hypertension, syncope, or any history of acute blood loss. Then there can be certain medications like systemic, inhaled, and topical steroids which can elevate IOP. There can be neurological symptoms like headache, weakness, dizziness, diplopia, or loss of consciousness. So ocular perfusion pressure. The term ocular perfusion pressure refers to the net pressure gradient causing blood flow to the eye. It is the driving force for the ocular blood flow. It may act as a risk factor or as a progression factor for open angle glaucoma. So ocular perfusion pressure, mathematically it is calculated by 2/3 of the diastolic blood pressure plus half of the difference between the systolic and the diastolic minus the intraocular pressure. So we can see in this equation that diastolic blood pressure has more role in the ocular perfusion pressure as compared to the systolic blood pressure. So this is the flow chart which is depicting that reduced ocular perfusion pressure with the reduced cerebrospinal fluid pressure, biomechanical properties, increased IOP, decrease in the blood flow may cause a primary insult. Along with that, in the presence of the primary insult will further result into the retinal ganglion cell mitochondria mildly affected. Then there may be reduced energy levels at the level of RGCs, which may lead to a secondary insult. And along with that, abnormal neurovascular coupling, along with the abnormal autoregulation, which can cause reduced ocular perfusion pressure. Ultimately, they will lead to the RGC cell death. So what is vascular autoregulation? Why is it so important? So it helps to meet the body need. Vascular tone maintain an appropriate level of hydrostatic pressure, avoiding edema. Regulation of this is maintained by autonomic nervous system, systemic hormones, and local autoregulation. So two types of stimuli, myogenic and metabolic, which can induce a response from local vasculature. Metabolic demand or supply can increase or decrease, which can modify the perceived need of oxygen and nutrients. And the metabolic factors can alter the vascular tone. So in the myogenic factors, as the blood flow increases, the smooth muscles of the vessels are stretched. This opens the calcium channels, and with influx of calcium, the muscle contracts and reduces the lumen of the vessels, which reduces the blood flow. So deranged autoregulation, there has been several studies which have shown this autoregulation to be deranged in glaucoma. This can be due to dysfunction of endothelial factors responsible for maintaining the vascular tone. What it does? The impaired autoregulation results in altered oxygen being supplied to the ocular tissue. If reduced, there would be an ischemic change, and increased level can lead to oxidative stress and ultimately cell damage. So let us see a case. A young 35-year male came with a history of sudden fall in vision. On examination, CRVO was diagnosed in one eye and high IOP in both the eyes. He was treated for a CRVO, but his glaucoma was progressing despite on maximum medical therapy, and the IOP remained in low teens. What was the cause? So we further investigated the patient with carotid vertebral and ocular color Doppler. So we got a plaque grade 3 to 4, which was noted in common carotid artery at its bifurcation, with thickened intima was noted in common carotid artery, suggestive of atherosclerotic changes. So ocular and spectral Doppler study is suggestive of occlusion of left ophthalmic and central retinal artery, causing a left-sided ocular ischemia. So reduced blood flow velocity and altered resistivity index can be predictor of glaucoma progression. Color Doppler imaging is good modality of the imaging and the hemodynamic study of the optic nerve vessels. It may help facilitating the understanding of the pathogenesis of glaucoma. So what we may do? Introduce the blood flow measurements into the clinical practice for diagnostic and follow-up glaucoma disease, which could help in the care of patients with glaucoma. Migraine, a very important factor. Patients with migraine have higher IOP, and patients with normal tension glaucoma have higher incidence of migraine. Migraine is vasospastic despite having a neural origin. Vasospasm may be related to endothelium-derived vasoactive factors. Both Raynaud's and migraine are associated with increased endothelin-1 and also the normal tension glaucoma. Cerebrospinal fluid pressure. Retinal ganglion cell damage occur at the level of lamina cribrosa, yet we measure the pressure across the cornea. Patients with open-angle glaucoma and NTG have lower cerebrospinal fluid pressure, where patients with the ocular hypertension have higher CSFP than controls. The translaminar pressure difference may be more relevant risk factor than the transcorneal pressure difference. Whether cerebrospinal fluid pressure is or will become easily measured, let alone modifiable, is still questionable. Sleep apnea. So obstructive sleep apnea, a chronic condition leading to apneic periods with hypoapneas and respiratory arousal, are an emerging risk factor for glaucoma. According to Wisconsin's sleep cohort study, the incidence is found to be 2 to 4%.
We are getting late. Please speed up.
Found to be associated with systemic hypertension, cardiovascular disease, stroke, and abnormal glucose metabolism. So 10% of OSA have glaucoma, and 50% of the NTGs have OSA. So Slurgy et al. Has also found the severity of OSA to be correlated with IOP, and metabolic and vascular changes results from the excess CO2 superimposed on endothelial damage due to hypoxia is probably responsible for glaucoma. So how do we measure it? We have an apnea-hypopnea index, which is used to indicate the severity of sleep apnea. So OSA is defined when AHI index is more than equal to 5, which leads to decreased blood oxygenation. So these are the vascular and the mechanical factors. So very important is the blood viscosity, which is also an important risk factor, which lead to decrease in the blood flow and stasis in the capillaries, which in turn lead to hypoxia. Hypolipidemia, which is another form of increased blood viscosity, which would increase the episcleral venous pressure and blood and result in consequent decrease in the outflow facility. This hemorrhage we have all seen. How is it affecting? And it is considered as a sign of ischemic optic neuropathy in glaucoma. So diurnal variation, again, it is a very important risk factor for the progression in glaucoma, and AJ's study has proved larger diurnal variation IOP increase the odds of visual field progression in eyes. And similarly, the diabetes mellitus has been equally found to be affecting. Like firstly, the diabetes would increase the impairment of microvessels and vascular autoregulation, which lead to further injuries, reducing the blood supply. Secondly, it would cause increase in the neuronal injury, and thirdly, it would lead to stimulate the synthesis and accumulation of fibronectin in the trabecular meshwork, which would promote the depletion of trabecular meshwork cells. And as we all know, hypertension is equally correlated with the glaucoma, and several meta-analyses has found systemic hypertension to be increases the risk of POAG. And what are the hypotheses? Reduction in the ocular perfusion pressure below the critical level of autoregulation, structural changes in arterioles, nocturnal dippers, and effects of antihypertensive, especially when taken in the night time. Thyroid disorders, similarly, in case of both hypothyroidism, which causes excessive mucopolysaccharide accumulation in the trabecular meshwork, act as a surfactant, which lead to increase in the IOP as well as aqueous outflow resistance. Similarly, in the Graves' disease, IOP may be raised as a result of contraction of the extraocular muscle against the intraorbital adhesions or orbital congestion due to increased tissue volumes. So what we can alter is ocular perfusion pressure, obstructive sleep apnea, vasospasm causing migrainous headaches, treat systemic hypertension judicially, stabilize diabetes, treat hyperlipidemia, and prevent IOP fluctuation or fluid overload like in breath holding and certain yoga postures.